Hello, and welcome again to our on-site coverage of ASH 2024 with ASH Clinical News. My name is Bethany Samuelson Bannow, and I am the Deputy Editor of ASH Clinical News. Joining me today is Dr. Jordan Schaefer, who's going to be speaking with us about his study on use of different doses of DOAC for long-term secondary VTE prevention. So thank you for joining us. This is a super interesting study.
Thanks for having me.
Can you tell us a little bit about what kind of raised your interest about doing this kind of study?
Yeah, so in practice, I largely see patients with venous thromboembolic disease, so deep vein thrombosis and pulmonary embolism, and been kind of following along the Amplify extensions trial and Einstein choice trials that looked at this topic. And then in 2021, there was the American College of Chest Physician guidelines that discuss the issue of dose reduction for patients that had completed 6 months of standard treatment for venous thromboembolic disease, and then where there was some clinical equipoise about continued therapy. And it was something that I was kind of reluctant to adopt in my practice as far as dose reduction, and but I did done it in some patients. But I wanted to look at what other people were doing, how much people were extrapolating from the exclusion and inclusion criteria of the clinical trials, and then did it really affect patient outcomes.
Awesome. And as you know, one of the challenges with those trials was that they were too small to really detect any meaningful difference in a bleeding rate when major bleeding happens in 1% to 2% of patients. So tell us about how you approached this in a slightly different way to get to answer that question.
Yeah, that was one of the things we kind of assume, and it makes logical sense that maybe being on a lower dose, if you were you needed an emergent surgery or had a bleeding event, that the drug would be out of your system, that much, faster. And so, we have the benefit in Michigan of this quality improvement collaborative called the Michigan Anticoagulation Quality Improvement Initiative, and that's for DOAC patients. We have 4 diverse centers in the state of Michigan that follow DOAC treated patients, and the data is collected. It's been ongoing for a long time using these predefined forms that are specifically designed to track anticoagulation quality, all the things that you'd think would matter for prescribing an anticoagulant or for bleeding and clotting risk factors. And so we have trained data abstractors. They often have clinical backgrounds, such as nurses, and they will check in with the patient, chart periodically, and abstract, a detailed set of information at enrollment, and then follow up with the patients for looking at bleeding and clotting outcomes. So we leveraged, that registry to kind of look at how dose reduction was affecting patients.
Very nice. And one of the things that was a little bit different about your study was you gave kind of an overall clinical bleeding number rather than focusing just on the strict major bleeding definition. So can you tell us a little bit more about how you defined any bleeding to look for those differences?
Yeah, we used, for our major bleeding outcome, we used the International Society of Thrombosis and Hemostasis definition, but we also have a composite outcome, which is any bleeding. And it's not the clinically relevant non-major bleeding from the ISTH. It's basically any bleeding event. It incorporates major bleeding, but also anything that would fall into the category of non-major bleeding, which could be, if the patient comes in and said, hey, I had a nosebleed last week, that would get counted as a bleed. So it could be, it's clinically significant enough for the patient to mention it and it to get documented in the medical record, but might not meet the other definitions of clinically relevant non-major bleeding that are used in other studies.
Yeah, and maybe can you just kind of give us a high-level overview of what your findings were with regard to VTE risk and regular bleeding or any bleeding and major bleeding?
Yeah, so the good thing about our study is we had a really long follow-up, average follow-up of 21 months in the study, which allowed us to get a little bit more power to look at differences in clinical outcomes. So our primary study outcome was recurrent venous thromboembolic disease, because that's what's important. One of the main things important to patients that have experienced a clotting event is understandably concern about what's my chances of having another deep vein thrombosis or pulmonary embolism. And we showed no difference between the patients that were maintained on therapeutic dosed anticoagulation compared to reduced or prophylactic dose anticoagulation in a propensity matched study. And then we looked at, in our bleeding outcomes, we did see increased any bleeding in our patients that were maintained on therapeutic anticoagulation compared to the dose-reduced patient population. And the therapeutically treated patients also had higher rates of healthcare utilization. So we saw increased rates of emergency room visits and hospitalizations compared to the patients that were able to dose reduce.
So interesting. And can you tell me a little bit about how this has changed or not changed your approach, and specifically how you select patients who would be appropriate for dose reduction, and how you counsel them now with this new information available?
Yeah, it has been something that's been educational just conducting the study for me. I think one of the first things was I spent a lot of time reading through the inclusion and exclusion criteria of the randomized controlled trials to say, well, and really getting familiar with that so that when I'm in clinic, I can really know, well, would this be a patient that could have been, that study could have applied to or not. And then, some patients will end up kind of in a gray zone where, for patients that meet the inclusion criteria, it's made it so that I do talk to them about dose reduction after 6 months of completing standard therapy. In our study, we did see that people were kind of moving that earlier, but, from what's been done in the studies, I still kind of follow that, 6-month period. And if they kind of meet the criteria, I say, hey, this is probably a good idea, to think about dose reduction. Then there's other people that I'm not comfortable dose reducing, people that have a really high clotting risk and wouldn't really have, been close to the, inclusion criteria for the Amplify extension trial and the Einstein choice. There I say, I feel more comfortable with you on, kind of the, full dose. And then there's some people that kind of end up in the middle where it's like, well, you don't quite meet the criteria, but but it's a little bit outside, but maybe we should extrapolate here and say that this could be a good idea for you. And so that's kind of what's fun about treating patients with venous thromboembolic diseases. Can kind of take into account their lifestyle and their preferences. And I've noticed some patients really have a strong preference to dose reduce and kind of get on that. It's kind of like a milestone of they've gone through some scary event and now they're 6 months out and we're not seeing any red flags that make us think that they need to be on the full dose. And so some of the patients do like the idea of dose reducing, and we make that choice. So.
Yeah, that's one of those things that you can never capture in an RCT is what's the psychological benefit of somebody just sleeping a little bit better at night knowing that they're on a different dose. And so that's where the counseling comes in, right?
Yeah.
So tell me, what do you see as the next steps for research? What do we need to do next to really kind of optimize this long-term approach?
Yeah, one of my main concerns, I really like our database, and the Michigan Anticoagulation Quality Improvement Initiative does a great job of collecting this data, and I think it's informative and can inform practice. I think the ongoing randomized, trials will helpfully, kind of confirm. One of my concerns is there's always a potential for, selection bias. Even though we tried to, compare two similar groups, there's still this possibility that kind of what I do in my practice too, where the healthier people might be the ones who are more prone to, have a dose reduction kind of thing. So it's not clear. So I think, confirming the findings in randomized studies will be important. There's some other centers that have other registries that aren't exactly collecting the same information, but a lot of the same information that we're also looking to, work together with them to potentially develop stronger studies and really look at some of these, subgroups of patients. And then I'd say the third thing that we are looking at is kind of this timing issue. One of the things that I kind of encountered in as we were starting to do this analysis is that this wasn't a randomized controlled trial where people were treated with 6 to 12 months of anticoagulation and then had the dose reduction. Some of the dose reductions were happening earlier, and so I want to look more at that patient group and see, is these patients that the doctor is, worried about and said, well, let's dose reduce you early because maybe you're bruising a lot or bleeding, something. Was there some reason as to why these dose reductions were happening earlier, or was this just, people choosing to to, kind of do that in practice. So we're doing some sensitivity analysis looking at timing of dose reduction.
Oh, great. Well, that's something that I will look forward to seeing. Thank you so much for talking to us and sharing the results of your research with us. This has been a great discussion. And thank you for joining us on ASH Clinical News on location at ASH 2024. Thank you, and we'll see you next time.